combination of fludarabine and busulfan proved to be one of the most effective conditioning regimen prior to allogeneic stem cell transplantation. And obviously, in this combination, one can modulate the dosage of busulfan. And you can go from the lowest dose, for instance, 3.2 milligram per kilo IV, to the highest dose, fully myeloablative, which is 4 doses, 3.2 times 4, 12.8 milligram per kilo IV. And obviously, depending on the patient characteristics, especially age and comorbidities, one can usually navigate, and this is what we have in the literature, between the flu-bu 2 doses, so an intermediate dose, 6.4 milligram per kilo IV, to the full dose myeloablative, which is fludarabine, and 4 doses of busulfan. And this fludarabine and 4 doses of busulfan is what we consider today the myeloablative but reduced toxicity conditioning regimen. And usually, if you have a relatively fit patient without significant comorbidities, actually this reduced toxicity myeloablative conditioning can be a valid option. It has been tested even in phase 3 randomized trials, and it proved to be superior to the conventional classical busulfan and cyclophosphamide, BuCy. Now, with this in mind, in some patient, especially older patient with some comorbidities, if one would like to decrease the intensity and limit some of the early toxicities, an option would be to use fludarabine and 3 doses of busulfan. This is the FB3. And actually, this regimen has been also published, and it allows, in an older population with some comorbidities, to achieve relatively low non-relapse mortality, around 10% at 1 year. So in summary, you can appreciate that the fludarabine busulfan platform is a very flexible platform that one can modulate depending on the patient, but also disease characteristics to optimize the final outcome after allotransplant. The balance between disease control and potential toxicity when choosing a given conditioning regimen, especially in older patients, is really a key question. This has been debated now for several decades, and there is no final conclusion. Obviously, in an ideal world, if we are talking about a refractory disease, you would like to intensify, to optimize the conditioning regimen and even achieve a fully myeloablative conditioning regimen. However, we know also that by pushing the intensity of the conditioning, you are going actually to increase the incidence of toxicities and morbidities. This is why, in my opinion, we should always be careful between this toxicity versus disease control balance. And in my personal experience, I would rather favor avoiding toxicity and mortality, even if we are suboptimal in terms of disease control, because then we are able to use post-transplant maintenance strategies. So you can see I am not much in favor of the fully myeloablative conditioning regimens in the older population, even if we are facing a refractory disease. I think one needs to prefer to get the graft in, to try to promote and stimulate the immune-mediated graft versus leukemia effect and avoid the complications of the fully myeloablative conditioning regimen. In the field of allotransplant, we usually speak about the age limit. However, the notion of age, of chronological age, does not capture the whole picture. And actually, we need to integrate in our reasoning and in the design of our transplant procedure, especially the choice of the conditioning regimen, whether reduced intensity, reduced toxicity, or fully myeloablative conditioning. We need to integrate the comorbidities, because age alone cannot predict exclusively the toxicities, morbidities, but also non-relapse mortality. Comorbidities are going to play a major role. Very simple example, we can have a patient who is 65 with no comorbidities, very fit. This patient is likely to do better than a patient who is 50 but who has cardiac comorbidities, renal comorbidities, suffering from obesity, etc. So combining chronological age, comorbidities, performance status is really crucial for the optimization of the transplant procedure. Obviously, the question is how to capture these comorbidities. And in the last 20 years, we've seen the advent of different scoring systems, the Charlson Adapted Comorbidity Index. You can use the Simplified Comorbidity Index. There are functional assessments. There are many scoring systems. I don't believe that one scoring system is better than another. I think the most important part is really to try to capture these comorbidities, to take them into account when designing the transplant procedure. And by combining chronological age plus comorbidities, but also we should not neglect nutritional status of the patient, psychological status of the patient, family environment, and many other parameters. By taking into account all of these factors, actually, we probably can allow to optimize the final outcome of allotransplant.